For patients who've undergone a biopsy procedure or an open removal of their tumor, craniotomy, it's very common for them to go home before the final diagnosis is available. I usually see patients back approximately a week after surgery, and at that visit I will make sure that they're doing well. I'll check on their medication. I'll often remove the sutures that were put in it at surgery. And most importantly, I'll be prepared to discuss the results of the pathology report. That means I'll have an answer about what the kind of tumor is. We've already talked a little bit about the grading scale, 1 to 4, and the types of tumors, the astrocytic tumors, the oligodendroglial tumors, and there are some other less frequent tumors. But I'll relay this information to the patient and try to put that into context. It's very difficult to predict for a particular patient what will happen with whatever diagnosis. When doctors get numbers about a patient's prognosis, they think of it in terms of big groups of patients. If I have 100 patients with a tumor like this, in how many of those patients will that tumor grow back in the next few years? That's not particularly useful when I'm talking to one particular patient, because that patient is really concerned about how they're going to do. They wish the other patients well, but they don't want to know out of 100 patients what's going to happen. They want to know what's going to happen to me. We'll do our best to tell you about the type of tumor it is and what the different treatment options are, but understand that your doctor can't know for certainty for you exactly what will happen. Now, a very common question I get at this visit is whether we were able to remove the whole tumor or not. And you might think that that's really something that is up to the skill of the surgeon. But in reality, I think the type of tumor is the most important predictor of that. We know from experience that with the higher grade tumors, the grade 3 and grade 4 tumors, that even if we remove all of the tumor that we can see at surgery, and we remove all of the tumor we can see on an MRI scan, and we can compare one from before and after surgery, that there will always be little fingers of that tumor that are still left inside the brain. And the reason for this is in part because the tumor occurred in the brain. When we do surgery on the colon, for example, we can go a foot to the left and a foot to the right, and we can get some of the fingers of the tumor. In the brain, we can't take wide margins around the tumor, so there may always be tumor cells in the normal brain. This is why for a patient who has a grade 4 tumor, the surgeon may say, I took out all the tumor I could see, and I don't see any tumor on the MRI, but I want you to strongly consider going forward with further treatment. And you might say, well, why do I need more treatment if you got all the tumor out? And that's because we can't see the little fingers, the little cells of tumor that might be hiding in the normal brain. But we can treat them with other forms of treatment, just usually not with surgery. So the main goals at the first visit are to educate the patient about the type of tumor it is, give them the details about the surgery that they may not remember from the hospital stay, and then start to talk about a treatment plan going forward.